Welcome to the Dusty Muffins, where menopause meets sisterhood and strength. We're three menopause specialists coming together to laugh, share, and empower you through the wild ride of menopause and perimenopause. Whether you're curious, confused, or just looking for real talk, you're in the right place. We're here to answer your burning questions, educate, and advocate, all with a dash of humor and a lot of heart. So pull up a chair and join the conversation. Before we dive in, please remember, while we're doctors, we're not your doctors. This podcast is for educational purposes only and is not a substitute for medical advice. We encourage you to partner with your own medical clinician to address your unique health needs. This is the Dusty Muffins. I am Dr. Rebbecca Hertel. I'm a board-certified osteopathic family medicine physician and a Menopause Society certified practitioner. I have a private telemedicine practice, and I see patients in several different states.
I am Dr. Aoife O'Sullivan, a board-certified family physician and Menopause Society certified practitioner, and I see patients through my telemedicine practice here in Oregon and Washington.
I'm Dr. Christine Hart Kress, a board-certified women's health nurse practitioner and menopause certified practitioner, and I see patients via telemedicine in several states as well.
All right, hi everyone. Welcome back to the Dusty Muffins. Today we're going to discuss the FDA's live advisory panel on July 17th, 2025. This focused on whether low-dose vaginal estradiol should retain the same black box warning as systemic estrogen. This is viewed on the FDA YouTube. You can actually go back and rewatch that. I've watched it live and rewatched it actually with my husband, believe it or not. He wanted to watch it and he was like really excited to listen to everybody. So I thought that was kind of neat too. This emphasized the significance of perimenopause genital urinary symptoms and the broader midlife treatment gap. So
I did like the fact that that panel was pretty diverse, although they had some what everybody calls influencers from social media on there. There was academics and the researchers. So I think they did a fairly good job at representation with one exception. And that is there were no advanced practice providers on that panel, which we take care of the largest proportion of these patients just by the number of us. And so not having an advanced practice provider, whether it be a PA or an NP, is really that lack of representation is really a health equity issue. That is my only really big critique about the makeup of that panel. I thought the people on there were fantastic, but I think that the advanced practice providers, there was nothing that was said on that panel that we didn't have the brain power to echo.
Nope, I agree.
Oh, medical schools and residencies have been ignoring women's healthcare for eternity, forever. And who's been taking care of all the midlife problems? The APPs have. So I totally agree with you. Yeah.
And I think we can step back for a second and say, okay, they were influencers, but it doesn't mean that they're still not experts, right? And I think that when there has been some backlash at the influencer stage, these are still practitioners that are very well educated and experts in their field. And so I think, we've all talked about that point. Like, there is that little thing going around social media, are you an expert or an influencer? And well, gosh darn it, we're all both. Like, we're experts in our field and what we do, but we're also influencing women to take a stance for their health, for their education, and for what they need for, their midlife care.
Yeah, I have really come to hate that word. I mean, if you want to call one of those doctors an influencer, I would love to put their CV up beside that word. These are highly trained physicians and surgeons. And just, there are people out there trying to reduce them to influencers. And
without credentials, right? Without having their credentials. It was inappropriate.
And if they weren't on social media and just had their CV, no one would think any less of them. And I think, I think that the people who are criticizing us for being on social media, I think they really need to take a hard look at the academics and the people, and the other providers that are in the actual exam room gaslighting their patients, gatekeeping hormone therapy. The only reason why we're over there is because it's a creative and fun outlet to educate, and we
Free
can reach more
education.
people. But we're
Yeah.
also educating in so many other forums. And when I lecture for the nurse practitioners, they don't refer to me as an influencer. They refer to me as a 30-year veteran of women's healthcare.
Right.
And so the reason why we're over there is because we enjoy the interaction with people and want to educate more women, because of these idiots in the exam room who are just being absolute assholes to
Yeah.
patients who
Yeah.
really just need to retire. And I've said this a million times: if you're not going to give hormone therapy because you are uneducated, you should not take care of these women.
Yep. Yep.
The biggest issue I have with it is these 90% of the people who are complaining about the influencers are on their Instagram account complaining about
Yes.
the influencers.
It doesn't make sense.
I'm sorry. Talk about gaslighting. I mean, are you telling me not to believe my own eyes? You're fucking
Yes.
there on your
Yes.
Instagram account bitching
Bullying.
about the other people on their Instagram
Yes.
account. You're
Bullying
bitching about
and
selling
little
someone
things.
vitamin D and you have a book to sell. Come on.
Yes.
Just,
Yes.
it's ridiculous.
It's,
Right? Form your
they're
own page.
right.
Form your own page and get on there and educate if you
Yeah.
think that there's other
Yeah, and
ways.
most of them are, Christine. That's what they're complaining from, their
yeah.
Instagram page.
And
Saying,
let's,
so they are an influencer, right?
yeah, absolutely. And
Oh,
I
I see
think,
what you're saying. Oh,
yeah, they're an
Yes.
I just
influencer.
thought you meant the stalkers, that are
No.
just on social
No, and
media
you
to
never know.
bitch.
They're probably paid, but we all just briefly touched on this before we started recording, and that was, this is a community. We are a community of practitioners that should be encouraging each other, uplifting each other, having amazing conversations for the greater good. And that came truth in this whole, little Nicki Minaj thing, and it was having these challenges of like, this is amazing. You just encouraged me to do something I never thought I could try to do. You just encouraged me. And that can be with any of these things. You just encouraged me to get onto social media where I never would have done it before, to educate women. So that's what I want this medical community, of practitioners to do. We should be lifting each other up in midlife and educating together and having great conversations together. We may not all agree on the same thing, and that is okay. But, bullying each other and tearing each other down is not cool. It's not sexy. It's not professional. And it's very, offsetting.
Get online and have an Instagram live with the person you're talking about.
Yeah.
And ask them questions and have a medical discussion, because usually it's a physician and they've been treating patients for years, and you're both on the same side and you're fighting the same fight, so you have lots to talk about. And then ask them your questions or bring up your problems or whatever about their supplements or whatever else is the issue.
And then we wonder why people say that they don't trust doctors. Well, I mean, look at what the hell's going on.
Yeah, it's ridiculous.
Yeah.
So it was nice to see everybody come together for the FDA panel. It was a real united front.
It was. And so what I'm interested in is what do these panels typically look like? So for the first time, we've had this type of panel. What did they look like before? And to Christine's point, did they have nurse practitioners and PAs in this research setting when they would typically have, these scientific get-togethers or panels? Does anyone know kind of how this worked? I know a few people have touched on that a little bit before we dive into, who was on there and what was said.
So I know that you can apply when they are open to sit on the advisory committees. I do know that the president of NPWH, which is the Women's Health Organization, has applied several times, and she's got quite impressive credentials both as FMP, CNM, and Women's Health NP, and has not been yet selected. But I think probably more so the case is that people, I mean, I didn't know that there was a open call for candidates and
No,
an application piece,
no idea.
because I don't think any of us ever thought, oh, I should be on FDA advisory committee, right? Like, I don't.
I know. How did that even come about? I'm like,
Yeah. So, I mean, I think probably, people closest to DC are
Mhm.
probably on most of those FDA, maybe coming out of the NIH, which, now has been, their research been gutted. So maybe, I mean, it's kind of interesting that, I'd love to know why they expanded to, uh, to physicians that have no research platform. It's kind of interesting.
It is
And
interesting.
who else was requested but didn't accept the invitation, because there are some folks that
Yep.
Lauren Stryker, Dr. Stryker's been pretty loud about the fact that she was asked to go and
Yep.
elected not to, because she didn't think that this process would be good for women's health long term, because this is not following the process on how you make a decision
Yeah.
to do black box warning, and was afraid that would, my understanding, would then be extrapolated to other things,
Right. Like systemic therapy and things like that, right?
or even like the in the abortion
Yep.
arena, some of
Yep.
those medications. So
Yes.
but
Yes.
yeah, I don't think anybody knew. So the advanced practice providers just, I mean, and the FDA didn't even probably think, I mean, how many work
Yeah.
for them, who knows.
Yeah.
I
It was
think this
interesting.
was it was a media event, right? And we know that we're not stupid. We know
Right.
that nothing may come of it, but let's not throw the baby out with the bathwater. I don't think
Hmm.
any of us are big Marty Macri fans. We know how he feels about for women's choice and abortion, which is not how we would think of it. But this was an opportunity. I was looking on it as an opportunity to get the word out,
Yes.
and I knew this was going to be recorded and this would be something I could share with patients and other clinicians. And having the FDA label attached to it gives it some sense of, professionalism, you
Yep.
would hope. So it was an opportunity to spread the word and hopefully take away some of the fear that's been around for the last 20 years. And I wonder how many people watched it and went, wait, estrogen doesn't give you breast cancer? Like that's what I was hoping would come from this.
Yeah.
But like Dr. Lauren Stryker was saying, this is not how you do things at the level of the government. And there has to be a proper scientific panel, and that's not what this is. This is a media event.
Yep.
So it'll be interesting to see, I suppose, what actually comes of it. But for me, I'm going to take what I can out of it, and I'm
Same.
sharing it because there was such good information shared during it.
Want the Dusty Muffins at your next event? We do panels, live podcasts, and talks that bring the heat, literally. Corporate, CME, or retreats, we've got you. So hit us up at thedustymuffins333@gmail.com or DM us on Instagram at thedustymuffins.
Do you think it got watered down at all? I mean, because my understanding with the when we started hearing about it was just to remove the black box warning on vaginal estrogen, which we'll talk about here about why that so needs to happen. But then, then there was the focus on the doctor's education, and then testosterone, and then cardiovascular risks, and then
Boom.
the breast cancer data, which was all really good information. But, and to your point about being a media event, I mean, do you think that the panelists should have focused on what seemed to be the goal? And maybe I got the goal wrong, instead of making it a why we should allow MHT and have the label changed for all hormone therapy. What are your thoughts?
I don't think there's a right answer to that. I think you
Hmm.
could have kept it all to do with vaginal estrogen and been a fantastic meeting.
Mhm.
But I have to say, we are living in crazy times, absolutely crazy times. And there are no rules anymore. And um, none of us know what Marty Macri could do with the swipe of a pen. For all we know, he could get rid of all these warning labels, label estrogens appropriately, label our hormones appropriately. He could take testosterone off the scheduled drug list. But we don't know what this man could do. There are no rules anymore. This government is loopy. So I personally was like, throw it all in there and see what we can get in, but I think there's no right answer to that. The purists say it should have just been the vaginal estrogen. I'm one of those people who can't leave any white on a coloring page. Like everything has to be colored in. So I definitely would have been like, yeah, I'm going to try for the testosterone. Definitely going to try for the
I
systemic
think
estrogen.
I agree too. I think if you invited the practitioners that you invited, knowing their platform and knowing their what's close to them, what is most important to them, I can't imagine that you didn't think that they weren't going to touch on those things, whether it have been right or wrong or indifferent, or I don't know what the letter said that said, hey, it's about taking the the black box label off, or bring to the table your 5 minutes of what you think is the most important. I don't know. I'm kind of interested to know. Or, was it just, hey, we're going to take our 5 minutes and yes, it needs to be off, but I'm really going to also take this time to talk about some other things that are really, really important too. It's interesting. And I kind of agree too. I don't know that we lost the concept of the true, the goal, but boy, you took advantage of some time to be like, hey, this needs to be done too, and this needs to be done too, and this needs to be done too while we're at it.
And I love like, like the people we read their studies, like you could see them, like, they're, more of the academics, and you don't see them as much. Like Barbara Levy, I was like, oh, and look at Joanne Pinkerton, who's right here in my neck of the woods. And I mean, we see Jim Simon because we're
every Monday,
things, but most people don't know about him.
And Philip Sorrell and Howard Hodis. Like, it was so cool to see everybody. It's like the Last Supper. It was like,
I know, the studies. And then I saw the faces and I was like,
yeah, it was our Super Bowl. It was our Super Bowl, right?
But I tell you, Jim Simon, and I was laughing so hard when he just came out there. It was like, it just doesn't do that. And I'm like, no, it doesn't.
And it's all related, right? Like if we go back to should we have done this, should we have done that? Let's be honest, it's all related. It's all wrong. Everything is labeled incorrectly. There is fear attached to everything. We're really harming women. We've loads of brilliant evidence on female to male transitioning with 10 times the dose of testosterone. Like, it's all wrong. We're doing everything wrong. We're harming women. So we've one chance to talk about this, because who knows if anything like this will ever happen again. Like, how could you not try and squeeze some of this in?
Yeah. And I loved the 5 minutes and how it was put together and the little slides and all that.
Have you ever seen so much squashed onto one slide?
No, you couldn't even, like, I'm like, what the hell is on that slide?
I'm like, screenshot.
It's in micro print. I would love to get those slides. One thing that resonated with me was Dr. Levy. She talked about not all hormones are the same, and that estradiol binds differently than conjugated equine estrogen. And she said that you can't classify the risks, but also said you can't classify the benefits the same. So, and we do all the time, right? Any benefit we get out of the WHI is, I mean, there are few studies, but not a lot on estradiol. I mean, it made me think for a minute, and I was like, are we extrapolating the benefits? I mean, like, can we say that? I mean, we think we can, because it's most like what we are making ourselves, but we only know the benefits for the most part for conjugated equine estrogen. So like, it makes me think, I'm always thinking when I am educating, I'm like, because I don't want to overpromise, right?
I've started with the docs and the keeps and the elite study, and that was all estradiol. Like, we do have studies. Sorry, Rebbecca.
No, I was going to say, when I talk about the WHI, I have now really have made sure to say, listen, it was conjugated equine estrogen. We have estradiol. We are extrapolating from other studies that this benefit also. But really, when we're looking at that study, it is conjugated equine estrogen. It was not estradiol. So, and women do appreciate that. Same thing when we talk about medroxyprogesterone acetate and then into the micronized progesterone. We believe this is null breast, as far as the MP, and but more data, more studies, as we always are saying.
Yeah.
Yeah. The other thing that I thought was interesting that she said was, I hear quite a bit, the over 65 or women over 60 approaching into the age 65, and their providers are trying to take them off the hormone therapy. And she made a point, not even the WHI encouraged a stop time. The grandmother's hypothesis of, best benefit if started doesn't, there was nothing in the WHI of risks of continuation.
No, I just saw someone recently, a new patient recently, and who said that her practitioner started her and told her in a year she needs to go off. And I'm like, well, where did that one come from? I've not seen that anywhere. It made zero sense. And she wasn't even close to 60. I thought, we're just making some shit up here.
Well, literally making shit up.
I think some of that, she pointed out, has to do with the fact that the med for geriatrics, which is what you are when you're 65, is on the hazardous list.
Yeah.
And it impacts the HEDIS metrics, which therefore then impacts reimbursement. And so maybe
I could get that at 65. Places, you're right. I could see that at 65, but not under 60 for them saying that. But maybe that's where she's extrapolating it from. I don't know. It was nutso.
Yeah. I just thought it was I thought it was a good point of you don't need to stop.
You don't, as long as
I've been hearing it more and more, and I didn't realize that it was probably an insurance thing.
Yes. Oh, yes. You get your MIPS and PIPs and HEDIS and all the things. I thought the panel, we can go through a couple. Dr. Heather Hirsch was on there. She argued that vaginal estrogen was categorically safe because it's not systemically absorbed. That's kind of, the big, most of the panelists on there, again, discussed that, that existing boxed warning is unsupported by evidence and is misleading, discouraging both patients and prescribers. I agree with that 100%. How many times have we had patients? I actually, I don't go on there and exit out because my patients typically don't bring in their vaginal estrogen, but I make it a point to tell them they are going to read something that is going to be, very scary, and they need to crumple that up and throw it away. And I tell them why they need to do it because, they all ask you, well, why is it on there then? And so then I have to go through, that just takes a lot of time to then educate, right? So, and in an insurance model, this education takes time. And so there lies the problem. So it may not be us as, those of us in this concierge space where we are private practice and can take more time with our patients, but an insurance-based model, when you have maybe 5 minutes after you have been roomed to then go through all of that, it's tough. That was my little soapbox.
Well, then even Dr. Pinkerton then was talking about the studies. Crandall had done a meta-analysis, and they were talking about the average serum level for women in menopause is 4.5 picograms per milliliter. And then when they're doing vaginal estrogen, it's somewhere between 4 and 14 picograms per milliliter. And then with the ring, it goes up to 19, but by day 2, it's back down to that 4 to 14, which is nobody's feeling good on an estradiol level between 4 to 14. No. But just about the fact that there's no systemic absorption, and
it just doesn't do that.
And your breast cancer patients, I think it was also looking at the breast cancer patients, and put the breast cancer patients that are, in treatment, give them some vaginal estrogen.
Yeah.
And just for reference, our husbands, their estradiol levels are probably somewhere between 20 and 40. Yeah. So that's just for reference. Men have estradiol too. usually around 20, 30, 40.
Mm-hmm.
So when you have your vaginal estrogen in and your estrogen's 19, which is as high as it gets and then goes down,
Yep.
that's
Yeah.
pretty safe.
I
I love
think,
that. I love that the
oh
men have
yeah.
estrogen. I don't study men's health. When I heard that, it just a couple of years ago, it just made me laugh my ass off. I'm like, yes,
Mm-hmm.
When
hence
you tell your patients
the
that,
man flu. That's where
yeah,
man flu comes from. Yeah,
when you're
more.
telling patients that, they're just like, really? I'm like, yes, yes, your spouse,
Yeah.
your male spouse
Do you
has more
do you
estrogen than you.
remember Dr. Casper said it might have been during her the Baby Boomers Are Pissed episode? Because I love that
Yes,
episode. I
so do
definitely
I.
listened to that so many times. So I think it was during that one. But she said about there was a study where they blocked men's hormones, their testosterone and their estrogen, and they lost all their libido. And then
Yep.
they just gave them back the estrogen, and they
Yes,
all
I
got their
do remember
libido
that.
back. I
Right.
thought that was very interesting.
That's right.
Um,
Remember
I'd
that.
say that was very difficult for Dr. Rubin to tell that story
Yeah.
about her mom. She was very brave to do that because I'm sure
And she kept it
you wouldn't
together
know if you
because
would just break down.
I was
Yeah.
on like breaking down a little bit.
Your
Yeah.
mom was
It
in the
was,
ICU for a
Yes,
long time
yes.
and sick.
yeah. And
I knew
that
that from a
information,
different thing, but
you
yeah.
know, just that story of of having to convince a first world country intensive care unit of the importance of preventing a urinary tract infection. I mean, working in the ICU, you lose patients to
Yeah.
urinary sepsis every day. They're in for a pneumonia. You're doing great. You've tried 6 antibiotics. The sixth one
Yep.
work. They've been on the ventilator for a month and they're getting places. And the next thing they get a urinary sepsis and they're dead.
Yep. Yep.
And to think that she had to go in there as like a grieving daughter, pretty much, and convince the staff to give her
And
mom
teach them.
something that we have guidelines for
Yeah.
and teach them. I mean, I really hope people listening to that really went, what the actual fuck? What the
Yeah.
fuck? Like that, we should not have to do that.
No.
Well, it's because
And this
ICU
is
nurses don't do anything that has to do with the vagina. They don't touch the vagina. The vagina doesn't exist except to stick a catheter in it. You know that. Just
well,
like they don't
put
do
a little
babies
vaginal
and
estrogen
babies.
as you're putting that catheter in. But I think people underestimate, even in just primary care or even internal medicine, I would say, that when you have a patient that comes in acting loopy, a female in particular, that is number one
UTI.
on my list. Go out and go give a urine down the hall right now. And Aoife, it is, I would say in the 90s of the percent that it is positive,
Mm-hmm.
right? I mean, it
Yes.
just is like, you guys, this is on our radar as just primary care and internists alone,
Yes.
right? Like, so it just, we're not putting two and two together here. Why is that happening? Well, there is a distinct reason why. Have you looked? Probably you're not looking at the vulva and vagina to actually see what has happened, that labia is gone and that there's clitoral adhesions, that, all of the other things that are happening too. Because I think if you truly understood that, which you should, if you are primary care, internal medicine, let alone, your GYN, taking care of elderly women, you need to know these things because we
But we're
see it
not
all the
taught
time.
that, Rebecca.
Nope.
Were you ever taught to how to
Nope.
examine a vulva in your training? Okay, I had
I, wa-
12 years of training.
I
I was
was
not.
only because we had a really strong women's health portion of our residency, and I went to extra training, and I cannot for the life of me where I went to go learn colposcopy and vulvoscopy. I
Oh,
did that in residency on my own. Yep. But otherwise, no.
Feeling off in midlife? I'm Dr. Rebbecca Hertel, and I offer concierge telemedicine across multiple states focused on hormones, weight, libido, and sleep, and longevity. Let's get you thriving. So visit www.osteopathicmidlifehealth.com.
I had a patient this in the last month or so. She's 65 on hormone therapy, just doing some tweaks for her. And we were talking about going to the gynecologist because, telemedicine, we haven't yet figured out how to do your prep smear via telemed. And she's like, well, her primary does her was doing her
Yeah.
paps and her annuals, and they said, no, we're not going to look at your vulva or anymore, and you don't need a pap smear. And I said, but you do need an exam.
Yes.
And I said, I agree, you don't need a pap smear. Your last 7 are normal, you have no history of,
Yep.
moderate to severe dysplasia, that's fine. I'm like, but someone needs to look at your vulva and look in your
Yeah.
vagina.
Yeah.
And she was like, well, they won't do it. I'm like, well, then you need to go see it. You got to go to a
Yep.
gynecologist, because you
Yep.
don't need paps, but you should still have a
That's
look.
right.
And, if you're not having pain, you don't need a bimanual, but someone should look at the labia, because, man, the number of labias that vanish, or get paper white, like a white piece of
Yep.
paper, and
Or
they
they
get
have
like
lesions,
sclerosis, right? Or they
cancer,
have polyps
vulvar cancer.
coming out of their urethra. I
Yep.
mean, we see that all the time, the caruncle, and
Yep.
they're
But
like,
if you're not taught
I
about
know,
any of
You're
those
right.
things,
I
and
know.
you do not know what they look like, and not only do you not know what they look like, if you
You
saw
What do
something,
you do
A,
with
you
it?
you
wouldn't
wouldn't
know what
know.
it was, and you wouldn't know what to do with it.
You're
Why
right.
would you encourage your patients
You're
to
right.
come back for
It,
you to look at the, like, it, it's
it
just,
goes down
it's
to the
such a
beginning.
systemic problem
Yes.
right back to the beginning of day
Yes.
one of training.
Yep.
Well, even in women's health, we used to tell people, once you turn 65, you don't need PAPs. Don't come to us anymore. Go to
Yes.
Well, that's
go to
where
your
primary
primary.
care
But
learned it.
Yeah.
That's where
I'm like,
primary care learned it from. Oh, that's right. That was part of, guidelines, I believe, at one point, right? I mean,
uh-huh.
am I making it up? Yeah. Okay. I'm like, I don't think I'm making that up.
Yeah, I think that's a really good education point that we probably, when we talk about, preventative care, like in teaching providers, we need to
Yes.
reiterate
Yes.
that now that but, until we got involved with Ishwish, I
Yes.
mean, that's where
And
we
paid for
really,
this education. Can we put that in? Like, we didn't
like,
just, like, it's not given to us. These
no,
are
very
things
expensive.
that you have to, we've all done on our own, and many of our colleagues on our own, paid money for, and had to take time
So
off
much
of
fun.
our jobs and to go to these conferences, to listen to these webinars, to do. So these are things that they need to be incorporated in these medical schools, nurse practitioner schools, nursing schools,
Right.
PA schools. They have to be. It's expensive, and we cannot expect, and I know we're going off on a tangent, we can't expect these other practitioners to fork out all of this money, because they don't get much CME to begin with, and they have to do all of the other things, their licensing, their DEA, their other CME credits for internal medicine, family medicine, whatever it is. And so these courses aren't inexpensive either.
Right.
So
But you can't
yeah,
do midlife without sexual health. And you
right,
can't and sexual health isn't just testosterone,
right.
it's making sure the vulva looks good and is
Yes.
really healthy. And that's so many other things that that need to be, addressed for sure.
Yep. Yep.
Um, one of my patients, who's a huge fan of the Dusty Muffins, wants us to do an episode about, the boomers and,
Yeah.
how to approach them. And I think from that panel, it was in presenting Dr. Manson's work, when they really talk, what I heard was over age 70, that's where the increased risk of mortality, stroke, and heart attacks are. And it was really good to hear that, because, I will start those over 60s after, looking at whole picture. But it was really, and I've had women over 70, like, I want a new start. And I'm like, well, here's the risks. I'm like, we got to really talk about that. But it made me at least hopeful for the 60 to 69-year-olds that never got the opportunity, that really would like to, they haven't slept in decades. And, some of them are still having hot flashes. And so that was really nice to have that included, that really the biggest problem in the WHI were those over 70-year-olds.
Yeah. And that
First
was
time
with
starts.
oral. And that was with oral conjugated equine estrogen,
Yeah,
which,
for our
I think,
listeners, like, we don't even have the
right,
information for
for transdermal.
women in their 60s and 70s who start hormones for the first time, because we would give you transdermal estradiol,
Mm-hmm.
which goes straight through your skin and into the
Yep.
bloodstream, not oral, which can increase your risk of blood clot and stroke and heart attack. And the way it acts, a large part of that in the Women's Health Initiative study was that medroxyprogesterone acetate, which seemed to follow the estrogen like the Grim Reaper and just undo all the good that the estrogen was doing ahead of it, especially at the level of the lining of the blood vessels and the heart.
Yeah.
So,
Yeah.
you know, I really feel like that piece of information has been weaponized against women.
Mhm.
And really,
I
if you scratch the surface, that's not what we're using now, you know?
That's right.
So
That's
we
right.
really need, we just, you know, I know we keep saying it, but we just need some really good studies. Let's start some fucking studies. Why everyone says it, you know? Can we just start some studies?
Can we just
Not
do
now
them?
that all our NIH money is going out the window, and
No, I
maybe
really
a
hope
different
that they
country can do it.
do. Especially around testosterone, like we're still on that exemption waiver this year of not having to see patients in person. And, as we get closer to the end of the year, we're all going to be asking each other the same
Mhm.
question since
Yep.
we're telemed, are we still going to be able to prescribe? And,
Yep.
you know, I, I thought Kelly Casperson
She did a
she was
fantastic job.
eloquent as always. But, and someone else recently talked about estrogen's always the damn star, but, we make 5 times as much testosterone. Testosterone is really the superhero. So I now talk about testosterone first because women don't realize how much testosterone they have.
Yeah.
Mm,
Yeah. No, she did a
I
really
know.
great job. And I really thought that Vonda Wright did a really nice job, um, you know, and was very passionate about bone health and what she has seen in the operating room and the women that have suffered from, their hip fracture and that they can't take them back and operate on them because they have a UTI. And, and the fact that 60% of hip fractures are females. And, we know anywhere between 25 to 30% of those women will lose their lives within the first year of a hip fracture, which that every time I say that statistic to me is impressive, and why we don't spend more time on preventing osteoporosis when we know that 1 in 2 over the age of 50 will have an osteoporotic fracture, I think is just absurd to me and is another one of my many soapboxes. But she did a great job.
She did.
Did we kind of catch everyone?
I mean, the great thing about it is that this meeting, most government meetings is invite only. If you don't have a CAT card, you're not invited. And the fact that this was, televised or YouTube, I don't know what you call it. It was on YouTube live, and now can be replayed. I think that,
you don't have to pay for it
for the open door policy, because otherwise we would have just heard about what happened. And so I think, when we talk about Estrogen Matters being something we recommend everybody, I think listening to this panel I would echo as another must should.
Yes, and we can link that. I think we can link that in the show notes too, so listeners can go and if you're like me, you can listen to it on like 1.5. It's fine.
Aoife and I can't think that fast.
I don't know if I retain stuff that I do now. When I listen to it on 1, they're like, so I feel like now I'm like, it's too slow.
It feels fine, but then I'm like, what the hell did they say?
I know. I'm like, no, this is fine. I can listen to 1.5, and then I have to like go back because I've missed that whole part where I was thinking this is fine, and then I'll start play again. I'll be like, yeah, this is fine. 1.5. Like, oh my god, go. Do you know?
Now sometimes I do miss it, but I would miss it on 1.0 too, because my brain starts to think about other things, or I'm working out and I'm counting my reps, and then I'm like, dang it, stop counting your reps. Just go until you're fatigued and listen to what you're listening to.
There was one thing I wanted to remind anyone who has watched the FDA talk was Dr. Howard Hodis. Like, I just did a yes at the end when he said, if you've been studying a compound for 60 years to see if it causes cancer, and after 60 years of looking at it, you can't say it causes cancer, then come on, guys. That is not something that causes
Doesn't
cancer.
do that.
Right? I mean, if
Right,
you think about anything else,
Yeah.
I mean, if you were thinking like, we've been studying cigarettes for 60 years to see if they cause cancer. We found pretty repeated, very quickly repeated studies showed,
Yes.
smoking causes lung cancer, certain dyes cause bladder cancer.
Alcohol. Can we talk about, I mean,
Alcohol,
alcohol is
exactly.
far less villainized than estradiol and estrogen. Can I just say that, as
Yes.
someone that does like to partake every now and again, and and I just can't because it goes in my head, makes me feel like crap, which is probably a good thing, but a little sad at the same time. Like, how many different cancers? What, 7 now? It just had to have a warning on all of the containers, the Surgeon General's warning. I mean, come on, guys. That is far less villainized, far less. We don't even educate as much, although we're starting to and we should be. But really, there are a lot more, power in these lighting physicians about estradiol than are they asking about if you're, vaping, smoking, and having a drink.
I know. I've been thinking about that a lot, that I should give up my wine club membership. I'm like, am I ready to give up alcohol? I really have been like, and I don't drink that much, but like, I don't like the way it makes me feel.
That's
But
terrible.
I like holding the glass, and I like having wine. But mostly I'm like, well, maybe I should start with giving up my wine club membership.
That's a little step. I'll put soda water in my wine glass or my champagne glass.
I
So,
know. I just haven't
but
gotten there. I know I need to do it.
you want to know what it is?
I
I
haven't
like the
gotten there yet.
taste. I don't care about the other. Like, if they had a non-alcoholic like wine that
Wine.
tasted good, I'm cool with that. That didn't have like a shit ton of sugar in there and all the other things. I would be fine with that. The same with like, a champagne too. Like, I would be fine with that. But
Maybe there is
let
one
me
and they
know.
can sponsor our podcast. And
Yes,
we
let
can
us
talk about how
know.
great their
Let us
wine
know.
is, their
Send us some
alcohol-free wine.
samples. We will let you know.
That's a great idea. Non-alcoholic wine thing.
Yes, yes. So, oh my gosh. All right. What a fun, anything else that you amazing ladies have to share on here? This was a fun little conversation.
I wish we knew that when they would release an outcome.
I
Like, are we
know.
doing anything, or are we just meeting for a media event?
But well, I mean, at least got a foot in the door. Maybe
Possibly.
we'll take that. So, again, it's cool that usually these things are done behind closed doors and it was, open. So we'll take it.
And no farm reps were there.
Yeah. Yeah.
And
So
I did find it interesting. So that the big investigator, the big epidemiologist in the WHI, the one that talked about the bandwagon, right?
mhm.
About during the WHI, he was the lead investigator.
Jacques Rousseau,
Jacques Rousseau
cardiologist
about
from hell.
hormone therapy in the bandwagon, and he was in the audience with a pin that said "I love the WHI." I was like, "Oh my goodness!" and
So look at
heckling
that
the
woman's
whole
face that they
time.
caught in the background. She's like,
I thought that I
that
was
was
like, "Oh my
fabulous.
gosh, this is better than General Hospital."
I know. There was a lot of hecklers I hear. And I'm just like, what are you heckling about? Like, we're 52% of the population. How do you not want the best things and the best outcomes? Just don't get it. Oh,
But we'll wait to hear the outcome. I guess we'll know how serious there he is.
yes. That's
There
look
he
at that
is.
woman. She's like, say what? Do you want to take it outside?
I know, I love that woman. Like, you're the idiot who ruined everything for us. If
Yes.
you are not watching this on YouTube, you at least need to go look at the old
Yeah.
man in his plaid shirt with his I
Oh
love
my
WHI
goodness. Oh, who wants to take us home?
Yes. So we all encourage you to go to YouTube and Google, or not Google, but put into the search box FDA vaginal estrogen. That should bring
And
it
we'll
up.
link
And
it. We'll link it also.
Yeah, we'll link it.
Yeah.
It's 2 hours long. Share this episode with your friends and loved ones and encourage them to watch it too.
All right. Make sure you like and follow us, and we will see you all next time.
Bye.
Bye.